Let's get started. Good afternoon, distinguished colleagues. Good afternoon. My name is Anna Gudjavtseva. I am the director of the consulting department of Philips, and today I'd like to welcome you at this webinar, International Experience Overview of Cardiac Units in Hospitals Recovery after the COVID-19 pandemic, as well as recovery of the system for providing cardiac assistance. This project has been implemented by Philips in partnership with the Scientific Research Center for Cardiology of the Ministry of Health of Russia, as well as with the participation of international cardiac centers. Today's webinar will be devoted to issues related to restoring the work of centers after the COVID-19 pandemic. It's a great honor for me to welcome our foreign guests, Professor Fausto Pinto, a professor from the University of Lisbon, who is president-elect of World Heart Federation, also a member and the past president of the European Society of Cardiology, Lisbon, Portugal, Professor Rafael Sadaba, professor at the Navarro University. He is a cardiac surgeon at the University Clinic of Navarra, Spain. Dr. Barbara Bellini is an interventional cardiologist at San Raffaele Hospital, Milan, Italy, and Dr. Rachel Lamy. He is also an interventionist cardiologist. He works at the Imperial College Healthcare NHS Trust, the United Kingdom. Dear guests, colleagues, welcome to our webinar. Good afternoon. Before we get started with our guests, I'd like to give the floor to Professor Sergei Boitsov, an academician of the Russian Academy of Sciences, Director General of Research Scientific Center for Cardiology. Sergei, the floor is yours. Thank you, Anna. Dear colleagues, well, it's a follow-up to the first part of our webinar. I would like to welcome our colleagues who joined in. First and foremost, our speakers from Portugal, Spain, Italy, the UK. And in the first part of our webinar, we managed to share our experiences that we had accumulated here in Russia. I mean, the experience of providing medical care, first and foremost elective surgeries after centers stopped treating patients with the coronavirus. We also shared experiences accumulated by our colleagues, which did not provide any care for patients with the coronavirus and continued to provide elective care. We also raised lots of questions. Unfortunately, we did not get answers to all questions because our experience is quite limited. I mean, working in the conditions when the intensity of elective care was reduced. So we're looking forward to information that is going to be provided from West European countries who, within the COVID-19 pandemic, did everything much earlier than we did here in Russia, and they have a lot of experience, which will be useful here in Russia. Anna? Yes, I'm going to speak in English, and those who would like to listen to the Russian channel, please turn on to Russian.
Sergei Anatolyevich, dear guests, so let us start our French cafe style webinar. So we will have discussions with each guest during 15 minutes per each guest. And I will ask our audience who are listening our webinar to type their questions into the chat box. And after the several questions from my side, two of them common for all the speakers, and one is a personal question. After that, our guests will be able to answer your questions from the chat. So our first guest is Professor Fausto Pinto. Welcome, Professor Pinto. Uh, yes, can you switch on your camera, please, so that we could see you?
It's on my camera.
Oh, okay, I can see you. Welcome, welcome, Professor Pinto. Professor Pinto, will you tell, please, us a couple of words about your unit and your hospital, just for introduction?
Well, first of all, thank you so much for this invitation. It's a pleasure to be here with my colleagues and with the audience. Special thank you and greetings to Professor Boitsov, Sergey, which I've known for some time. We worked together actually some time ago in Kazan in Russia, and I've been in Russia quite a few times, and certainly when hopefully we'll be able to travel again, we'll be very happy to join you again in your beautiful country, and also to my colleagues that are part of this discussion. Well, I work here in Lisbon at the University Hospital of Lisbon. It's the main hospital in my country. It's a university hospital, about 1,100 beds, and we have all different specialties and all different types of procedures and activity of a normal big university hospital, big in terms of my country, and I would say that for our size, this is quite a relevant hospital. We also have, of course, all the teaching and all the research facilities. We have a couple of other buildings that are also used by the medical school, which I'm also the dean at this moment, for teaching and also for research. Please go ahead.
Sorry, I'm so sorry for interrupting, Professor Pinto, but I would propose to jump to the first question in our today's discussion. So you can see it on the screen. So which clinical outcomes and changes on the blood circulation system do you expect to see for those patients who had carried out COVID-19, such circumstances like coronary diseases, arrhythmia, arterial hypertension, or something else?
Well, we know, well, first of all, this is a new virus, and it's a new disease. It's something that we're learning from each other. It affected many parts of the world. It started in China, and then it went basically all over the world, and that's why it's a pandemic. We know also data coming from experiences from other groups, and it's been already published a few studies that show that heart disease is one of the complications for this disease. And also patients with cardiovascular disease, they are at a high risk of developing the disease and also of having complications related with coronavirus. Here in my hospital, we had a few patients who developed heart disease related with COVID, mostly related with arrhythmias. We had also some conduction abnormalities, so patients that had the need for placing pacemaker, and we also had what has been described also cases of very heavy burden of thrombosis. So we had a few acute coronary syndromes and also some cases of intravascular disseminated coagulation with also some thrombotic complications. So the main potential complications of these patients with COVID related with the cardiovascular system are either arrhythmias, development thrombotic or a prothrombotic state, and acute coronary syndromes. We still don't know in the long term, because we don't have long-term follow-up, what will be the sequelae of these patients. We do know that in the acute stage, the development of cardiovascular disease is a prognostic marker. So the patients who will develop cardiovascular disease in the setting of COVID, they have a worse prognosis than the patients who don't develop cardiovascular disease, and also the patients who already have cardiovascular disease, they also have a worse outcome and worse prognosis than patients who don't have previous history of cardiovascular disease. In terms of the patients who survive, we still need to have some more data to understand what will be the long-term impact of this process. The other related disease that we see in viral disease are myocarditis, so patients develop acute infection. We did have a couple of those cases, and that has also been described by other groups And we know that in myocarditis, there is a chance that these patients will evolve into cardiomyopathy. And that's something that also is now being described, and that needs further investigation, particularly in terms of having more data related with more groups of patients. There are ongoing registries that are accumulating data, international registries that are accumulating data, and that will provide that information for the future.
Thank you very much. And we go to our next question. You can also see it on the screen just in a couple of seconds. What is your vision on how the reduction of non-STEMI cases will influence the mortality rate in your country? And what is the share of dead patients with high cardiac risk in the overall?
Well, I think what you mean here is the fact that we had, and that was actually a problem that happened in many, I would say probably everywhere, particularly during the peak phase of the disease. There was a decrease in the number of patients who came to the hospital with acute coronary syndromes. In our case, we had a 50% drop in the first few weeks in patients admitted with acute coronary syndromes. And we know that these patients, either they stayed at home and they died at home, or they developed some complications, or they waited too long. And we had actually a few patients that came late, like a week after, and we did see some complications in these patients. We saw some cases of cardiac rupture. We saw some cases of patients coming with acute heart failure because of acute myocardial infarction that was not treated acutely because the patient stayed at home. We actually had a few patients that had to undergo mechanical support, but overall 50% drop. So that was very relevant. And that's actually one of the issues that we are facing. Now things are changing a little bit more in terms of coming back, not yet to normal number of patients or percent of patients we used to have, but coming back to, I would say, normal levels. And that's very important, because one of the messages that we are conveying to the population is that despite the fact that we have this disease, and it's a disease that we still don't have a cure for the disease, the other diseases, they still exist. And for those diseases, we do have treatment. So patients with an acute MI that will come to the hospital within the first few hours, we can do a very good job. We can treat that patient with good results. If the patient doesn't come, then he or she may die or may develop severe complications. So this is a very important message that now all the scientific societies, the medical communities, the scientific communities are giving very strongly to the population, encouraging the people to come if they have a problem, and they should not stay at home if they have an acute problem that can be treated, and otherwise it can evolve into a very complex situation. So this is a problem that, and I know that talking with other colleagues, this is happening in other countries. This is a serious problem that we have to really make sure that we convey this message. So it's very important that if there is a condition that can be treated, the patient should come to the hospital and should be treated for that condition, because otherwise we are not only losing patients for COVID, but we are also losing patients, and we already have data showing that there is an increased mortality, not only because of the COVID, but also because of the other conditions that are not being properly treated. And it's a shame, because for these conditions, we do have treatment. And that's something that as a medical community, we are focusing very much, trying to improve the way we can access our populations to make sure they understand this. But it's a difficult job.
Thank you. Thank you very much, Professor Pinto. We have one more questions, and then we'll start with the question with the chart. So Natalia, can you show the next slide, please? Professor Pinto, what changes has COVID-19 pandemic brought to the clinical process in your clinic? I mean, comparing your operational activity before, during the pandemic, and in the recovery period.
Okay, so I think we can divide in these different timings. So first of all, in my country, we had, let's say, the fortune of being one of the last ones to be hit in Europe. So we were seeing what was happening in other countries like Italy, like Spain, like UK. So we had a little bit of time to prepare. And what happened was that basically the hospitals were converted, particularly the big ones, defined the places where the COVID patients will be allocated to. And what happened also in the beginning was actually to stop most, in some cases, all the elective procedures and only doing the urgent or emergent cases, and prepare basically for the hit by the COVID patients. So there was a reorganization of the departments in order to be able, particularly for increasing the capacity for ICU, for intensive care patients, and that implied not only expand that in the hospital, but also stop some of the activity, the elective activity that was normally done. So on one hand, it will not occupy the hospital with these patients, non-acute patients, and on the other hand, also not bringing the population to the hospital where they could be infected. And this is at the time where we were still not totally sure or understanding what to be the dynamics of the infection at that stage. So this represented basically the first month in our hospital, which was, I would say, 6 weeks, which was the time during what we had here in my country was a lockdown with the state of emergency in the country. And so during those 6 weeks, we reduced substantially the elective procedures, and we kept doing, of course, all the acute cases, all the emergent cases, and of course, the COVID patients that needed to be treated, we had to separate. So we had a very clear separation in terms of the patient flows, COVID, non-COVID. We also had some sort of areas, buffer areas, where we had the patients who we did not, still were waiting for the results, and then they will be moved either to a COVID area or to a non-COVID area. And so that was very, I think, very well organized. Then when we moved to the next stage, which was when the country started to reopen again, we also started slowly with the process of opening the activity for the elective patients. And we established priority lists. So we did kind of risk stratification of our patients, and we started at a slow pace, but we started with elective procedures for the high-risk patients. For instance, we restarted with TAVIs, we restarted with elective cases for angioplasty, for PCI. We restarted also for device implantation for the patients that were considered of higher risk. And there was something that slowly started, and now I would say at this moment, which represents about 2 months after, so we had the country started to open at the end of the first week of May. So we have about 2 months now of activity, and I would say that at the moment we are about 70 to 80% of the normal activity we had before the COVID, depending a little bit on the activity. We also started to reopen the outpatient clinic, and one thing that was done for all the patients who came into the hospital for procedures, all these patients were tested, and therefore there was previous knowledge if the patient was positive or negative, and only, of course, for elective procedures, only the negative patients will be admitted. If there was a positive patient, that patient will be treated for the COVID before being admitted for whatever procedure was to be done. And of course, for the acute patients, we will do what we did. We have the fast tests. So if it's a STEMI, for instance, the patient is tested when he's getting into the room. The patient is treated as if he or she was COVID positive. We have the results in about 1.5 hours for these patients. And once we finish the procedure, we already know if the patient is positive or negative, and then we can allocate the patient either for a COVID or a non-COVID area. So overall, this is what we are doing, we have been doing, and how we have been basically stratifying our population. So we are going back now. In 2 months, we went slowly back, still not totally to normal activity, of course, because the timings are a little bit different. It's more, we are recovering, I would say, about 70 to 80% of our activity.
Yeah, thank you very much, Professor Pinto, for such an extensive answer for this question. It's really, really valuable. And we have some questions from chat. I will ask the one. Were there any changes in overall amount of endovascular interventions and cardiovascular surgical procedures at the different stages of COVID-19 pandemic in your country and in your clinical in particular?
Yes, as I mentioned, during the acute phase, all the elective patients were stopped. So for 6 weeks, we did not do any elective. Well, only if there was a very specific situation. So we reduced the elective procedures substantially. Just to give you an idea, for instance, for cardiac surgery, we normally have between 7 to 8 patients a day, and we reduced to 1 patient a day. In the PCI, we stopped the elective procedures, so we did only the emergencies or urgent cases. Now, as I've mentioned, for cardiac surgery, we are, I would say, 90% back. For the cardiology procedures, we are about 70 to 80%, and that means for including devices, PCI, and so on.
Okay, thank you. And we have time only for one more question, but it's quite interesting. Do you expect a rise in severe cardiovascular diseases cases due to the fact that patients are afraid to come to the hospital? And what other measures could be just to offset this trend?
Yeah, that's, as I mentioned, that's a very important issue. And I do believe that there will be an increase in heart failure. I do believe that many of the patients, and that we will have data, there are some ongoing registries that will show us that. We already have some data showing increased mortality overall, and some of these patients were included in that mortality. And I'm sure that many patients who did not come to the hospital and then even STEMIs or non-STEMIs or some decompensation, they will increase, I'm sure, the number of heart failure patients we will have to deal with. The way to try to minimize this, again, as I mentioned, I think we as medical community, and that's what we are doing, I know everywhere, is trying to explain to the population that they should come, try to encourage people to feel safe, to give confidence to the people that they can come to the hospital. There are separate flows, separate paths, so they should feel safe, and they should feel that they have to come if they have a problem, because otherwise what could be treated can actually become a very significant problem, which otherwise could have been treated at the early stage with good results. So that's an ongoing work that all of us have to do in our communities.
Yeah, thank you very much, Professor Pinto. I believe that all the knowledge and information which you shared would be very, very valuable for all the Russian healthcare practitioners. Thank you very much again.
Sure, thank you.
And I would like to invite Professor Rafael Sadaba from Spain. Professor Sadaba, please, welcome.
Hi, Anna. Well, first of all, thank you so much for the invitation. It's a privilege to be here with you, trying to share our experience with the COVID pandemic with all of you. And I hope this is of some help for some of the physicians who are just yet to see the worst side of this.
Yes, thank you very much, Professor. And we will we'll start with our, say, traditional question, which is common for everybody. Could you please elaborate a little bit on which outcomes and changes on the blood circulation system do you expect to see for those patients which carried out COVID-19?
I think this is a very interesting question, Nana. We've heard mostly about the pulmonary complications of COVID, but which I think is quite clear that COVID also affects the endothelium of the cardiovascular system, and it causes a procoagulative status in the whole body. I must say that we have not seen so many arterial thrombotic problems, but we have seen certainly an increase in number of pulmonary embolism and vein thrombosis, more than acute coronary syndromes. From the coronary point of view, we have seen a number of cases of patients presenting with very typical chest pain, angina-like chest pain, with an increase in troponin and enzyme levels. But then came to the cath lab, and the angiogram was normal. And these patients, obviously, this was caused by myocarditis, of which we don't know much about. We are carrying now a follow-up study, doing cardiac magnetic resonance to these patients, because we believe that these patients may have some, this myocarditis may have affected the heart, and this can have consequences in the long run. So yeah, those are mainly the problems we also, and I think this is very important, and I think it might be of help. In those patients who were on ECMO system, we've had more incidents of thrombosis in the lines, in the membrane of the ECMO. I remember 2 of them, in which, you know, it's very rare that you have to do this, but we have to change the membrane because it was just thrombosed. We decided to put all the ECMO patients on either higher dose of heparin, and I'm sure that Dr. Bellini has had plenty of experience with this also in Milan, to prevent this kind of problems. So special care with ECMO patients and their prothrombotic status. That's an important message, I think.
Thank you very much. I would like to go to another question. Natalia, can you show this slide, please? Yes. So the next question is the following. The next. What is your vision on how the reduction of non-STEMI cases will influence the overall cardiac mortality rate in your country? And what is the share of such patients?
Yeah, as Professor Pinto said, certainly there've been a fair amount of deaths secondary to cardiac conditions that we are not aware of. I don't know if I could share my my screen, Anna, because I would like to show you an interesting slide. This one. Can you see it now? My PowerPoint.
It's loading.
Well, this is a figure which on the, it tells you about the deaths. This is for our region of Navarra. Is it coming up now?
Yes, we can see it.
Okay, so this is the number of deaths. Okay, this is a calendar weeks, and this is for last year for the same period. So this is the 95% confidence interval, and this is the deaths that you would expect. Now, suddenly, this is the COVID time. This is from March, hold on a sec, from March to April. So there is a huge increase. Sorry, I've lost my mouse. Well, you can see that black line in the period of from March and April. This is the observed number of deaths. So the blue line, this line, is that what you would expect to see. This is overall deaths in the region for this period of time. This is what you would expect in a normal year. This is the number of deaths that we had this year. Now, this is part of these deaths are obviously secondary to COVID, but only a small proportion of these deaths are secondary to COVID. Most of them are due to unknown causes. And among these deaths, certainly, there will be those who died out of cardiac conditions. We did see a decrease in number of patients coming to hospital with acute coronary syndromes. Why? Well, there is a number of reasons for this. First, patients didn't want to come to hospital, as Professor Pinto said, because they were scared of getting infected with the virus. But obviously, also, those primary care physicians were also fearful of sending these patients to hospital just in case. So there are a number of reasons for this, but certainly we have seen less acute coronary syndromes coming to hospital, and certainly these patients have died outside hospital because of their fear to come to hospital.
Understood. Professor Sadaba, the next question is, how cardiac patient pathway look like in your reality, in your unit and in your hospital? I mean, the pathway of the patient starting from outpatient clinic to the rehabilitation.
Yeah, so we are now back to normal in our hospital. We are now doing more cases than before because for over 6 weeks we stopped all routine work. We were doing only emergency cases. Obviously, that has caused an increase in the waiting list, and now we have got to catch up with these patients. These patients are now coming sicker because they've been waiting for longer to have their operations. How have we changed the circuit? Well, as Professor Pinto said, we've changed at all levels. At the preoperative status now, for instance, and this is something that we started to do during the pandemic for diagnostic purposes, we are now using more CT scanning than coronary angiography. This served us doubly, first because it was easier to do the CT scanning, and that would give us information on the status of the lung on patients who were potentially sicker. Now we are getting more information for CT scan that we would, because we are getting more and more patients with CT scans. In the outpatients clinic, whereas before we would see one patient every half an hour, in the preoperative clinic now we have expanded that to 45 minutes, so 2 patients don't wait outside at the same time. Obviously now our patients have to wear face masks when they come to the outpatients clinic. Before they come to surgery, within 48 hours prior to surgery, they have to have a PCR test done. And then that's checked, the results are checked before they come into the hospital. If they are positive, obviously they cannot come. We have created a COVID-free circuit. So in our hospital, we are lucky to have 2 separate ICUs. So all the COVID, we don't have any ICU COVID patients any longer, but recently all COVID patients were in one particular ICU, was all the surgical patients were going through a different ICU. So they were going through a COVID-free circuit. Something which is also different is now in the consent form, in the consent form for the surgery, now we include a COVID form to inform the patients that although it's very unlikely that they will catch COVID during a stay in hospital because of all the preparations, still the hospital cannot take responsibility for that. Yeah, so as I said, we introduced a few changes. Oh, rehabilitation, we've stopped the rehabilitation. We are not doing rehabilitation yet. The rehabilitation technicians and nurses are contacting the patients by phone, following them up, because our rehab clinic is not only rehab, it's kind of follow-up as well. So they are instructing them on what to do, what type of exercises, dietary advice, etc.
I see. But why it is so? Just to minimize the contact, or? Because
when they come to the rehabilitation gym, so they are that is a close place. You get many patients together. They have to come to hospital, and we're still trying to keep patients away from hospital.
Okay, I see. We have some more questions from the chat. Do you foresee medical organization coming back to conventional modes of operations, or do you think that they will function in a new reality from now and further?
I think that from what I have seen, and we were one part of Spain which was really hit by the pandemic. So we were in a critical situation. We were able to be well prepared, and we were always in control. But we are now coming back to normal, and I think that other than the PCR, other than patients only allowing one visitor per patient in the hospital, which will carry on for a while, I don't think that we will change that many things once we go back to normal.
Mm-hmm. Thank you. Another question from the chart. Those surgeons and interventional cardiologists who worked in the red zone, it means the zone with COVID infected patients, were they isolated in the specific ward, or did they continue their routine work despite working with infected individuals?
That is a very interesting question. So first, only from the interventional cardiology point of view, none of the interventional cardiologists were sent over to the red zone because they were needed to be on call, and only one of the surgeons went to the red zone. The other cardiologists who went to the red zone, they were only allowed to be there. They couldn't come back to the normal areas. My colleague who went to the red zone, to the COVID ICU, he was kept there and he was not allowed to come back. Then what we did is that both interventional cardiologists and surgeons teams, we were always make sure that we didn't mix together in the hospital at the same time. So we always have separate teams. So either one team was at home, another team was in hospital, and vice versa. So the interventional cardiologists had two teams. One would stay at home, the other team would be stay at hospital, same in cardiac surgery. So just in case one team got infected, we could keep the infection, as limited as possible.
And what happened with the unit in this case, if the team is infected? Is it sealed, closed, or?
No, so we were lucky enough not to have that situation. And none of the interventional cardiologists and none of the surgeons got infected. We had a situation in which 80% of the echocardiography department got infected. That was in the very beginning of the pandemic, when we still didn't know, and then many of them got infected. One of the things that we found very useful from that point of view, instead of bringing the patients to the echocardiography lab, we've made use of the handheld echocardiographers, which have been shown to be extremely useful in these circumstances, because you didn't have to move either the patient to the echocardiography department, obviously, and you didn't need to take the big echocardiographer to the COVID part of the hospital, but the handheld ones were very useful.
Thank you very much. We have another very interesting question from the chart. What should we do to prevent the second wave of COVID? I mean, what clinical societies should do to prevent the second wave?
What we've seen, and I'm sure that Dr. Bellini has seen that as well, and Professor Pinto, now that we are over the pandemic, you can see people relaxing far too much. And I think that is inevitable that we have new cases again. There is little we can do other than keep advising people to be careful, to be on guard, because this is going to happen. Obviously, we now are better prepared. In our hospital, we only had 38 ICU beds in the normal ICU beds. Now we can jump to 80 in matter of a few days, 3 or 4 days. We can now go back to more than double the number of ICU beds. Now we have the system is trained is prepared for another pandemic, but how to prevent it? I think is difficult, because people, people go out, people like going out, getting together, and that's going to be a problem.
Okay, Professor, the last question from our chart, it's written in Russian, so I will be translating right away. So, do you use any short-term isolation of all incoming patients for elective procedures, just to avoid coronary COVID-19 infection in the hospital?
Okay, so yeah, that's a good question. So what we do about that is, when we call the patients for surgery. We ask them beforehand, we ask them whether they have any symptoms, COVID-like symptoms. We ask them whether they might be in contact with somebody who may have been COVID symptoms or the infection. Mm-hmm. If the answer to these questions is no, then they come to hospital to have a PCR test done for COVID. That's got to be exactly 48 hours before the day of admission. So they come to hospital. There's a specific place, which is just this building just outside the main hospital building, where they have the PCR. And if this is negative, they just come and we take no more measures.
Okay, thank you very much. If you don't mind, and still we have some more minutes, there is a very interesting question as well. In your opinion, what is the role of outpatient coronary angio or PCI in COVID era? Do you have any protocols or algorithms for procedure management for such patients?
Well, I'm sure that Dr. Bellini will be in a better position to answer that.
Yes.
But yeah. So for routine PCI, the procedure is very much similar to the one we have for surgery. So patients are asked about symptoms or contacts. They come for a PCR 48 hours previous to coming to hospital. If this is as a primary PCI, then all patients are treated as COVID. Now, over the last 3 or 4 weeks, we have a rapid, reliable test, which is you have the results in 15 minutes, but we are very limited to the number of these that we can do every day. So now we are starting to do this. So all urgent PCIs get the fast test done, the fast ELISA test done, and then they proceed with.
Okay. Thank you very much, Professor Sadaba. Thank you for such a discussion. It was very interesting for me and for our audience, I believe. So it was a pleasure to host you here.
My pleasure as well. Thanks.
Thank you very much. And we are going further, and our next guest is Dr. Barbara Bellini from San Raffaele Hospital in Milan. We all know that Italy and Italian healthcare was hit strongly during the pandemic, and I would ask Dr. Bellini first of all also to say a couple of words about the unit where she's working on, and also about the hospital where she's working. Yeah. Dr. Bellini.
Good afternoon, Anna. Thank you.
Hello. Hello.
Very happy to share our experience with you. Yes, I work in San Raffaele Hospital in Milan, Italy. Milan is located in the Lombardy region, which was the region which suffered the most from COVID-19 pandemic. So we had a very dramatic situation at the beginning of COVID pandemic outbreak, with many patients coming to ICU and no beds for all patients. In fact, in the first months of COVID pandemic, we had a high mortality in Italy, as you may know. Now, fortunately, we're starting to recover. We have no more patients in the ICU, but during the COVID pandemic, we had to increase our ICU numbers, the ICU beds for COVID patients, and we dedicated the 4 ICU specific to COVID patients, taking also patients from other hospitals, Bergamo, Cremona, which were the cities that were hit the most from COVID.
Okay. Thank you, Barbara. Our first question, which is also common for all our guests. So, what is the clinical outcomes and changes on the blood circulation system do you expect to see for those patients who was hit by COVID-19?
Yes. As already said, COVID-19 patients present a high prothrombotic risk. In fact, in many patients, up to half of patients, we saw that there was also pulmonary embolism associated to COVID-19 pneumonia. In some patients, the presence of the clots in the lungs were not depending from an embolic phenomenon. In fact, our researchers described another kind of phenomenon which was called microclots. So they thought that the virus damage to the endothelial cells and subsequent inflammation might cause the clots formation directly in the microvessel of the lungs. So this patient can do well, we can recover with heparin administration. And in this kind of patient in which the thrombotic phenomenon of the lungs was seen, they had also a more dramatic onset of respiratory failure, and most of them required intubation. Another aspect of COVID-19 regarding the cardiovascular system was the presence of acute coronary syndromes. Our study, our group, together with the Humanitas Research Hospital, recently published a paper on circulation about STEMI patients with COVID-19. And as Dr. Sadaba said, we found that in 39% of patients, we found no culprit lesion. And maybe this was due to the fact that this patient had myocarditis or a type 2 myocardial infarction, but we were not able to discriminate the two causes because it was a retrospective study.
Thank you. And related to our second question, which is also common, the reduction of non-STEMI cases, do you see that it can influence somehow the overall mortality rate in your region caused by cardiovascular causes?
Yeah, for sure. During the COVID outbreak, we observed a very important reduction of all acute coronary syndromes, both NSTEMI and STEMI patients. As Professor Sadaba said, maybe it was due to the fact that the patients had fear of coming to the hospital because of possible infections. Even if from the very beginning, the very early phase, we established different pathways for COVID and non-COVID patients. So this risk was low, but anyway, patients were scared. They didn't come to the hospital in time, and we saw many late STEMI. We saw some complication of STEMI that we haven't seen in many years. We had some cases of ventricular septal defects requiring surgery. And in some patients also, the very first presentation of STEMI was an embolic phenomenon, peripheral embolic phenomenon in patients with a large myocardial infarction with left ventricular thrombus formation. So usually this kind of patients require medical attention earlier, and in this phase we had a higher mortality for cardiovascular patients. So I expect to see in the next months more CTO and more heart failure because of myocardial infarction not undergone to revascularization.
Thank you. And Dr. Bellini, and what are the specific changes in the treatment of a critical cardiac and neuro cases like acute coronary syndrome, as you said, or stroke, shown in your hospital or in your region?
Yes. During the COVID pandemic, the lumbar division completely reorganized itself, completely reorganized the STEMI networks. In fact, before COVID, we had almost 50 cath labs to take care of acute coronary syndrome syndromes patients. While in the COVID pandemic, we reduced these cath labs to just 6 that were hub for STEMI, so that all STEMI could be centralized in this hospital, and this allowed to save ICU beds in other hospitals for COVID patients. In my hospital, we had a different cardiological emergency department, which we tried to keep COVID-free. All patients with acute coronary syndromes were tested, underwent PCR test, the fast one, and were brought to the cath lab and treated as possible COVID patients. So the staff wore all the equipment, the 2 pair of gloves, protective glasses, a special coat, and in this way we tried to protect the staff from COVID exposure and also the patients, because for the end of the revascularization procedure we had the PCR results, and we were able to send the patient or to cardiological ICU if the PCR was negative, or to special COVID ICU if the test was positive.
I see, thank you. We have several questions from our audience. So the first one is, do you perform PCIs on outpatient basis? And do you think that this approach could help to reduce the patient time in the hospital and to reduce the risk of infection? Yes,
this is an interesting question. In my hospital, we do not perform PCI on an outpatient basis. In case just of coronary angiography, it is possible that the patient doesn't spend the night in hospital. So the patient undergoes coronary angiography and can go back home. In case of a PCI, the patient stays overnight and is discharged the day after. But sure, using the radial approach, I think it might be safe to discharge the patient the same day, so to reduce the risk of infection. And as previously pointed out, all elective patients in our hospital are asked before the admission telephonic questions about their health, their symptoms, or their contacts with possible COVID patients, and undergo a PCR test in a special building outside the hospital within 48 hours before the hospital admission. If the test is negative, they can be accepted.
Mm-hmm. Thank you. Another question. Did you manage to reach the same volume of procedures which you had before pandemic in the recovery period?
We are trying to increase the number of procedures now that we're in the recovery phase, but since we had a reduction in the number also of beds, because we try to prefer single rooms, or in the past we had triple rooms that are no more allowed, we are not able to reach the same numbers as before. But for example, in my department, there are 16 beds dedicated to PCI or TAVI patients. Now we have just 12 beds, because also other units moved in other departments. For example, now in the same floor we have the clinical cardiology department, the cath lab beds, and also the nephrology department. So we had to reduce, but we're trying to keep the numbers high in order also to reduce the waiting list and to go back to normal.
Dr. Bellini, and do you have any mandatory rules to keep the beds in your hospital for possible COVID cases?
Now we have closed the ICU beds specific to COVID patients. We just kept the COVID emergency department. So all patients with respiratory problems go to that department, undergo the PCR test, and if positive, they are sent to a special ward with infective disease and internal doctors. As I said, we have no more patient in the ICU, no COVID patient in the ICU. So now the situation is really improved.
And how does your hospital and the management of your hospital are preparing or maybe taking already some actions for this possible second wave?
Actually, as I said, we were able to increase very quickly the number of ICU beds. First of all, because we had one old ICU which was not used anymore, that was reconverted. And second of all, because we were able to convert very quickly open spaces, the basketball yard, to ICU. So I think that in the future, for a possible second wave, the hospital should keep flexibility in order to react very quickly in case of second wave of COVID.
I see. At least they know what to do.
Yeah.
Because they had an experience. Thank you very much, Dr. Bellini. I believe that all your experience and information which you shared today will be very valuable, not only for interventional cardiologists, but for all healthcare practitioners in Russia. Thank you very much again. Thank you. And I would like to invite our last guest for today. Please welcome Dr. Rasha Alami from UK. Dr. Alami, my traditional question. Could you please introduce your practice and your hospital where you're working?
Thank you so much for inviting me to speak today. So my name is Rasha Alami. I'm an interventional cardiologist at Imperial College London. I work in the centre of London in an area that was very hard hit by COVID and was probably one of the areas of really the peak of the epidemic in northwest London. We have a number of district general hospitals, so smaller hospitals that refer to us, which became really very overwhelmed with COVID in the midst of the crisis, and that had a great impact on our services at the tertiary cardiac centre where I work.
Okay, thank you. And our first question, which is also common for everybody, as probably you have mentioned, what changes and outcomes from the blood circulation system do you expect to see in future for those patients who has carried out COVID-19?
So I think we've heard a lot about this already from the other speakers, but what we were expecting to see and what we were told from our Italian colleagues and to some extent from our colleagues in China was that obviously this is a disease that impacts the respiratory system but has a large impact on, as we heard, the endothelium and also on thrombosis. We were expecting to see a large increase in terms of acute coronary syndromes or ST elevation presentations in patients with thrombotic complications. But in honesty, we didn't see as much as we expected. We saw some patients right at the beginning with those kind of complications, but very quickly that stopped happening. That may be because very quickly in our pathways in the UK, the anticoagulation protocols were really increased. So a lot of patients were put on, within the ITU, on heparin infusions. There was also a dual antiplatelet therapy protocol. And in fact, we ran a trial within our cardiac unit and a number of centres nearby, randomising patients with troponin elevation and COVID to dual antiplatelet therapy. And perhaps that had an impact maybe on some of the presentations. We thought we would see lots of myocarditis. We maybe didn't see as much of that as we expected, but we had a real difficulty with myocarditis because even where we suspected myocarditis, we were really unable to put those patients through our MRI scanners mainly because they were very sick, but also because we were worried about the infection risk of putting them through the scanner. And so we probably underdiagnosed some of those complications. We certainly saw pulmonary embolism, and we had a number of patients who we discharged who then later came back with pulmonary embolism. But again, because of the changes to our anticoagulation protocols, that number reduced quite quickly.
I see. Okay. And what about the influence of the reduction of the non-STEMI cases, STEMI and non-STEMI cases, to the overall cardiac mortality rate in your country?
Yeah, so that was really very stark and became very obvious very quickly, and was probably something we hadn't realized would happen. So it was really an unexpected implication of COVID. I have a slide actually that I could share. Maybe if you could just allow me to share that, that would be great.
Yes, I think you have a right to share.
Great. So actually what we saw, so you can see here on this slide, the impact that the sort of wider implications that we had in COVID in the UK. So actually lockdown in the UK was in the middle towards the end of March. And essentially the number of attendances that we had for myocardial ischemia went down by 50% across the UK, but particularly in London. We saw our hospital, very rarely would we do a primary on call without seeing, at least one or two, usually at least 3 primary cases in a 24-hour period, so ST elevation MIs. And we had many, many days of 0 cases. As we've heard before, that may have been because the patients stopped coming in. It may have been one of the main issues that we also had was that our patients often present to either the district general hospitals and then come to us. Those hospitals were overwhelmed, and so there were lots of patients, I think, that were avoiding going to those hospitals. But also the London ambulance service was totally overwhelmed, and so it's possible that patients were not picked up in time, perhaps they didn't make the calls. We also know that our primary care physicians, because they essentially closed their services, and the only option for most patients was that they would email their GPs or speak to them over the phone. I think there was a lot of underdiagnosis of potential acute coronary syndrome or ST elevation MI, and that's definitely been a kind of sequelae of COVID that we didn't expect.
I see. Okay. And another question, Natalia, can you please show it on the screen? Yes. So what is your strategy to recover elective cases? What specific actions or protocols do you and your colleagues follow in order to manage this patient flow with chronic cardiac diseases?
So I think we do many of the things that you've heard from the speakers, but there's some extra bits that we had in the UK. So one thing that happened very early on in March is that it was announced that the National Healthcare System had paid for contracts with all of our local private hospitals. Those contracts were paid for initially 2 months, but actually the period has been extended and we now have contracts out to September. The private hospitals were forced essentially to take NHS cases. And that meant that we quite quickly were able to recover some elective services. The private hospitals were meant to be COVID-free. So as soon as swabs were available, the pathway was that we currently still deliver this 2 days a week. Our hospital has access to 3 cath labs on each of those days. We have 1 EP lab, 1 structural lab, and 1 coronary lab. They are meant to be just elective cases. Those patients have to isolate for 2 weeks, and they have to have swabs 2 days before. If the swabs are negative, they come for their elective cases. And essentially, we have been able there to do elective TAVIs, elective angiograms and PCIs, and elective pacemakers, and then elective EP procedures. So that did mean that from April, we were able to start doing some elective work outside of our hospital, where all elective work was suspended up until 2 weeks ago. And the way that we have started elective work in our hospital is we've produced these gold pathways. So essentially there is, I guess it depends on how your hospital is structured, but in our hospital, it is possible to isolate the way up to cath labs and to the day ward. What happens is that we have a lift that was previously for our acute patients, so that the ambulance service could arrive, patients go straight in that lift, go straight up to the assessment area, and then go straight to the cath labs without problems accessing the rest of the lifts in the hospital. Now that lift has become our gold lift. The patients, again, self-isolate for 2 weeks. They then have swab 2 days before in a temporary structure that's in the car park. They then, if that swab is negative, they come straight into the gold lift. They go upstairs actually onto our private wing, which is now NHS, and that wing is just for COVID negative patients. They then go down from that wing straight to the gold cath labs, where there are 2 cath labs that have to be COVID negative at all times. And then they go back up after their procedure, up to that private wing, and then from there they exit. That means that they never enter the rest of the hospital. What's also important is the staff on the gold days also don't enter the rest of the hospital. And the staff, it's not perfect, but the staff have swabs every 2 weeks. So it is possible still that a staff member could contract COVID and be asymptomatic and potentially operate on COVID negative patients and potentially infect them. We haven't found a way to get over that because we don't have enough staff to have staff that are just on the gold rota, and all of our interventional cardiologists need to also be on the primary rota. So it's not a perfect system, but it's a bit better because it reassures the patients, and therefore we found that more patients have accepted coming in for their elective procedures.
Mm-hmm. Thank you very much. Very interesting experience. Dr. Alami, and have you considered any office-based cath lab procedures, both for diagnosis and for PCIs with stenting, or this approach is not that common?
No, so in the UK, the approach for, office-based out of the hospital elective procedures doesn't exist. And we have
regulatory obstacles or why? Or is just a practice?
Yeah, I guess our healthcare system has always been based around the National Health Service, and even within the private sectors, there are private hospitals where we deliver PCI. It's mainly, I think, because what's been discouraged in the UK is single operator or mini operator practices that are hard to regulate, or that's how it's seen. So you're always within the wider system. So no, that's not possible to us here.
Okay, and we have one more question to you. What methods of additional assessment during PCI would allow to reduce the stage of treatment for multivascular lesions, and as a result to cure the greater number of patients with a less time, I would say, period of time?
So I don't know if I totally understood the question. The question is, how do we treat multivessel disease?
I would say the question is more about some additional methods of assessment. Maybe it's devoted to FFR or IVOS or other. Mm-hmm.
Yeah, so we in our centre, we are a very high volume intravascular imaging and intravascular physiology centre. So we use physiology in 70 to 80% of our cases. It depends on the operator practice. Some of us are even more. And for intravascular imaging, in my practice, it's about 70 to 80% of cases. Mm-hmm. In others, it's less. For COVID patients, we have practiced in almost the same way. I must admit that sometimes with COVID patients, you wanted to be quite quick and you didn't allow yourself necessarily as much time to optimize things. In our COVID labs, we have only access to an integrated system. We deliberately didn't want to bring in any of the mobile systems because obviously there would be problems with cleaning them because we share them between 5 cath labs. So we actually only used IVOS, not OCT, because our OCT system is a mobile tower. So we left that for the COVID-free areas. In the elective work now, we have returned to doing elective work exactly as we did before. So we do a lot of physiology because, of course, we really believe in physiology and we kind of believe in putting stents in where they matter. And we have been doing intravascular imaging as much as possible to optimize the results. In fact, even in my COVID patients, we did a lot of imaging because at the beginning, particularly when we were really worried about the thrombotic state, I felt that an underexpanded stent could not be a good thing in a patient who was also prothrombotic. So we did do a lot of imaging there as well.
Okay, thank you. And the last question we have, so how do you manage organizational changes for the staff primarily and on the facility planning and the hospital staff load and some safety features in order to provide the better care for the patient in the post-COVID period?
Yeah, so maybe I can show another slide actually.
Yes,
just
please go ahead.
Kind of shows that. So actually we had some quite interesting experiences with our staff. So firstly, we saw a lot of sickness in the workforce, especially right in the beginning. That was mainly actually, I think, because we didn't have access to swabs at that stage, which was a little bit disastrous. So a lot of people were getting sick. They weren't sure whether the symptoms were just a normal cold or flu, or whether it was actually coronavirus. They had family members who were also potentially sick, and people were having to self-isolate, not knowing if it was COVID. We lost about 40% of our workforce in the first few weeks, and that had a massive impact on our rota. The staff were obviously in self-isolation, and we had a lot of problems with morale and stress because of these kind of new working patterns. Also in London, one of the things that became very difficult was shopping for food, because our hospital canteens didn't really cope with this new pressure, and they usually only operate on a 9 a.m. to 5 p.m. system. And all of the shops were closed, the takeaways were shut. It was really difficult to actually feed the staff. So we had lots of problems also with transport, because the transport systems in London became very reduced with the lockdown. So many people were having problems getting in. And the other thing that we had was that we cancelled all annual leave and study leave for our staff from March. And in fact, it was only reinstated 2 weeks ago. And today is my first day of leave. So we had some real problems with morale because people were very tired. So we also faced a lot of fear and stress around COVID. So one of the things that we did was we did some simulation training in the very early stages, to try and prepare ourselves for how we put on PPE, how we communicate in the cath lab, and you can see here with a mannequin, how we do CPR in the context of COVID. And this was very interesting because it revealed many, many problems in the cath lab. So for example, we discovered that we had no mechanism to communicate with outside. Our mobile phones obviously didn't work, that Skype or any other system was not working within the lead-lined room. And when we ran out of kit, we had no way of getting it very quickly. So we developed an intercom system and a runner who would stand outside the cath lab and get kit when we needed it. We also discovered that in the context of cardiac arrest, when everyone's wearing all of this kit, it's impossible to work out who anyone is. So we kind of needed to iron out ways of communication in the lab. And I would really suggest that you think about simulation if you're trying to work out how to deal with these patients. And then finally, just to sort of talk about some of the protocols we put in place. So we had to develop a new staff rota, because in our system, we have 14 consultant cardiologists on the rota, 7 of whom work between 2 hospitals, the district general hospital, and then they come to our teaching hospital 1 day a week. All of those people very early on were repatriated to their lead centre, and they were not allowed to come to Imperial at all. So we now had to staff a rota with half the number of staff. So we were doing double the number of shifts. We also had to staff the rota for sickness. So we developed a buddy system so that at any stage you were essentially the second person on call. So on that night you had to be available to come in at any point if the other person became sick or there was a problem with transport or childcare or anything else. We developed new CPR pathways because we needed to protect the staff, and we felt that cardiopulmonary resuscitation was an aerosol generating procedure. So our protocol was that no CPR could be delivered until we had worn PPE. We developed some new pathways with the London Ambulance Service so that they could inform us. So on the bleep system, what they do now is when they call with a primary, they say COVID possible, COVID definite, or no COVID. And this comes out on the bleep. So as you're coming into hospital, you know what to expect. We ourselves as cardiologists had to have quite a lot of respiratory and ITU training to deal with some of the new stuff we were seeing. We developed some new pathways for our heart attack patients, including the option for thrombolysis, which we actually used once, only once, on a patient that was very sick at another hospital who couldn't be transferred, who had COVID. They had thrombolysis, and then when they settled, they came to our hospital the next day to have rescue PCI. We had to find PPE, which was quite hard. And as I've discussed, we had COVID cath labs. So we have one red COVID cath lab, and we have these red COVID wards, some of which we've closed now, but these were just sort of different pathways that we developed.
Thank you very much, Dr. Alami. Thank you for this information which you shared with us, and I believe that it will definitely will have a positive impact on the practice of your Russian colleagues. Thank you again.
Good luck.
Thank you, you too. Once again, I would like to thank all the guests who joined today's discussion, and I would like to thank our audience for such a brilliant questions to support our today's discussion. And to close today's session, I would like to pass a word to Professor Бойцов. Sergey Anatolyevich, please, the stage is yours.
Большое спасибо.
Thank you very much. I'd like just to figure out, should I speak on the Russian channel or English channel? Anna, could you help me? You can speak any language you like. Okay. All right, so it's up to you. First of all, I'd like to thank our foreign guests who found the time on their schedule and shared their experiences of work in the clinics of Portugal, Spain, Italy, and the UK. I'd like to thank Professor Fausto Pinto, Rafael Sadaba, Dr. Barbara Bellini, and Dr. Rasha Alami. What we've heard now, that's information straight from the horse's mouth. It's invaluable information which corresponds to our experience, our observation, but there were some nuances, as I might put it, that many Russian listeners noticed, and these nuances are particularly important because our colleagues in Western Europe are ahead of us in terms of this pandemic process. They are 2 months ahead of us. And each story presented by our foreign colleagues had a lot of things in common with us, such as answers to the questions that had been prepared earlier, but there were also some nuances which we'll have to think about and mull things over. As for the comparison between what you have in Western Europe and here in Russia, I would say the following. Indeed, we can see in Russia and here in Moscow, which was ahead of the entire Russia in terms of the spread of the pandemic process and the manifestation of the pandemic process, we can see an increase in the number of myocardial infarction, but it wasn't quite a significant one. But there were an increase in MI with there was an increase in the number of STEMI patients, but a drop in the number of non-STEMI patients. Then we thought, what might happen with the mortality rate as soon as the pandemic is over? Professor Sadaba showed a wonderful slide demonstrating that after the peak is over and when we go back to normalcy, so to say, before the peak, the mortality curve continues to go down. I mean, cardiovascular mortality. This can be explained, and this is the phenomenon we had in Moscow 10 years ago when we had the Moscow heat and Moscow was covered with smoke due to fires outside, forest fires outside Moscow. But after a peak in the death rate in August. There was no the second peak in September. And in 2011, the situation improved. As for cardiovascular diseases, well, we remember that heat phenomenon, there were no increase in the mortality rate. Colleagues, please switch off your mics. Only Sergey can speak right now. Thank you. Well, probably this can be explained by this heat phenomenon when during the pandemic, only those people died, those patients died, well, who usually die as a result of cardiovascular problems. This is the explanation. So what do we have in Russia now? We do not have the data of the Russian Statistical Service. Again, we're lagging behind by 2.5 months or 2 months at least, but we will probably see an increase in the mortality rate, unlike West European countries. And this will be due to the fact that we did not have a large number of deaths from COVID-19 in Russia in general. Maybe, well, this process will be longer in time, but I hope that in general, the 2020 mortality rate in Russia, like from March to June, will be the same as in 2019. It is also important to mention that from January 1st to mid-March, even the end of March, this 3-month period, in all federal regions of Russia, there has been a significant reduction of the mortality rate from all diseases as compared to 2019. That was very unprecedented because for many years in the winter time, we haven't seen any drop in the mortality rate. Usually we were concerned by the fact that there was a minor increase in the mortality rate in the winter period. Well, we can also explain this phenomenon. We had no flu epidemic, and that's an important factor impacting on all-cause mortality. And another factor is that last winter was very mild, and the cold factor in Russia is more important for us than the heat factor as far as cardiovascular death is concerned and all-cause mortality rate is concerned. But this is just our guess, but we need to act in accordance with the existing protocols, and they are basically the same as those in West European countries. Maybe when I mentioned the word protocol, I was not quite right. That's an official document of Rospotrebnadzor, Russia's consumer protection service, signed by the Surgeon General. This document defines safety rules for health staff and patients with the indication of specific organizational elements of providing healthcare. This webinar, in my opinion, as Bagrat Alekian has mentioned, can serve as the foundation for preparing some methodological document that might be useful first and foremost in terms of going back from COVID-19 care provision to elective procedures provision. The risks are still here as far as the Russian Federation is concerned. Well, patients and healthcare workers can contracted COVID-19. The risk is still very high, especially inside inpatient hospitals, although we have, the situation in Moscow, a trend towards a decline in the morbidity rate, towards a decline in the mortality rate, but nevertheless, well, we've reached a plateau, and now there is a trend towards a decline. That's why, colleagues, first and foremost, I urge you to respect others. Well, wear PPE, wear masks. Well, when you are at work, that means respect for your colleagues, thus you reduce the probability of infection. Well, if, God forbid, you are infected and you don't know about that, also follow other rules of providing medical care within your healthcare facility and respond to specific situations. I am calling for Russian healthcare managers will respond to any facts of possible infection, even if you have suspicion of infection. Only in this case you can prevent negative events, you can prevent a disaster. By disaster, I mean an outbreak that can happen anytime when the entire hospital can be shut down, because that would mean a threat to our staff, a threat to our patients, and that means no care for patients who need elective procedures. Well, from the bottom of my heart, I'd like to thank the organizers of this useful and interesting webinar. I'd like to thank Philips. I'd like to thank Anna Kudryavtseva and Alexander and Konstantinos Sachev, who made a lot of efforts to prepare the material, and the entire team, which did a lot in organizing this webinar. Thank you very much, Anna. Thank you, Sergey. Thank you, colleagues. Thanks for this discussion. Thanks for sharing your time with us. Stay well and goodbye. Bye-bye.